Bone marrow failure presents with an insidious onset in children who may or may not have phenotypic abnormalities. Children with Fanconi anemia have often been recognized prior to the development of bone marrow failure. Symptoms: easy bruising, petechial rash, gum bleeding, nose bleeding, paleness, fatigue, fevers, unusual infections. Signs: bruises, petechiae, mucosal bleeding, pallor, flow murmur, short stature, micronathia, microphthalmia. Upper limb abnormalities, absent or hypoplastic thumbs with or without absent or hypoplastic radii. Café au lait spots. Investigations. General investigations. Complete blood count, the hemoglobin, erythrocyte count, and platelet count are variably decreased. The mean cell volume is increased to greater than 100 fl. Neutropenia may be present. In Fanconi anemia, thrombocytopenia or leukopenia precede pancytopenia. Peripheral blood smear, the erythrocytes are large. The leukocyte morphology is normal. Platelets appear decreased and may be smaller than normal. Respiratory count, normal or decreased. HbF quantitation, increased. Bone marrow aspiration, bone marrow cellularity is moderately to severely decreased depending on when in course of disease bone marrow is obtained. Special investigations. Ham test, positive in paroxysmal nocturnal hemoglobinuria. Chromosomal fragility testing with diapoxybutane, increased fragility. Diagnostic of Fanconi anemia. Renal ultrasound, horseshoe kidney, other anatomical abnormalities. Plain films of upper extremities. MRI of spine, increased fat and spinous processes associated with decrease in hematopoietic elements. Complications. 10% develop leukemia, 5% other cancers, 4% liver disease, hepatic tumors. Pelias hepatis, treatment. Diet and lifestyle. A varied, healthy diet is encouraged. There are no specific restrictions. When peripheral blood counts are normal, the patient is encouraged to participate fully in normal activities. Thrombocytopenic patients must avoid activities that place them at risk for head injury and the potential for intracranial bleeding. Neutropenic patients are required to seek medical attention with the development of significant fever. Pharmacologic treatment. Standard dosage androgens alone, oxymethylone, United Pharmaceuticals Incorporated, Buffalo Grove, Illinois. 2 to 5 mg/day orally. Nandrolone decanoate, 1-2/kg/WK. Androgens with corticosteroids, above doses of. Androgens with prednisone, 5 to 10 mg every other day. Special points oxymethylone, associated with hepatic toxicity. Nandrolone decanoate, when given IM, associated with pain and bleeding at injection site. Other treatments, supportive care. Transfusions. Erythrocytes and platelets should come from non-family members. Cellular blood products should be irradiated and look reduced. Transfuse erythrocytes with post-transfusion hemoglobin, goal, 10 to 13 g/dl. Platelet transfusions as needed to prevent spontaneous bleeding episodes. Hematopoietic growth factors. Concern about leukemogenic effects of cytokines. Bone marrow transplantation offers cure for aplastic anemia and prevention of possible development of leukemia. Preparative regimens are difficult for Fanconi's anemia patients to tolerate. Decision for bone marrow transplantation in Fanconi's anemia patient requires discussion with experienced pediatric hematologist and pediatric bone marrow transplantation physician. Treatment aims to improve peripheral blood counts. Approximately 50% of patients will respond to corticosteroids. Response in erythrocytes first, followed by leukocytes. Platelet rise may not be observed for months. Some patients lose their Response. Prognosis. Median survival, 16Y. 25% live beyond age. 26Y. Prognosis improves as more is known about the disease. Follow-up and management. As with other rare hematological disorders of childhood, patients with Fanconi anemia should be primarily treated by physicians familiar with this rare disease. Surveillance for liver disease, progression of bone marrow failure, and leukemic transformation is necessary.